My name is Jim Kenney, and I am founder and president of JT Kenney, LLC, a managed care pharmacy consulting practice. Previously, I worked for Harvard Pilgrim Healthcare for 38 years in pharmacy management. I'm here today with Dr. Mark Redding, Associate Professor of Medicine and the Director of the Center for Bleeding and Clotting Disorders at the University of Minnesota Medical Center. We're going to answer audience questions we collected from our webcast about hemophilia care coordination and cost optimization. Next question, I'll have you answer first, Dr. Redding, and then I'll provide some commentary from the health plan perspective. Do payers and PBM-owned specialty pharmacy companies create barriers to a hemophilia treatment center-based specialty pharmacy by requiring factor to be filled at their own pharmacy? And if so, are there workarounds to do this?
Yeah, it's a good question. A lot to potentially talk about and unpack here. I think from my perspective, this certainly happens, and it does, frankly, create some barriers for us. I guess from my perspective, the thing that I really see is that this often adds an additional layer between the patient and the HTC team. Information on bleeds, information on adherence, these sorts of things. This is often information that is being collected from the patient, but it's not being collected by the HTC. And one of the things that I hear very frequently from my patients is that they're unaware of the fact that this information isn't automatically flowing back to the HTC. And so sometimes, they voice frustration when we ask them the same questions. They're like, I've already given you this information. And in fact, that information isn't always free flowing back to us. And it can create confusion at times about, who's doing what and so on. So I think we need to be careful and recognize that this can be an issue and work to make sure that doesn't happen. Obviously the way to work around this is to just make sure that if a payer is requiring a patient to get their factor elsewhere, that there is a good line of communication between the specialty pharmacy and the HTC, and we certainly could work on improving that. The other thing that I will say I hear from my patients fairly regularly is that they often have difficulty getting factor on short notice if they have to go through an alternative pharmacy rather than getting it from the HTC. Often it's because the pharmacy is located distant from where the patient is, whereas we're right here in town, and so that delay in getting factor, if it's needed on an emergent basis, can sometimes be a problem. And so if that is a situation that exists, again, one way to break that barrier down is just to make sure there's a mechanism in place by which we could fill for that patient if the need was urgent. So a lot of potential issues there, and I think just again the real key to breaking down this barrier would be just better communication between the HTC and the specialty pharmacy.
Well, those are great points, and I think it's incumbent on the payers to make resources available and try to encourage the sharing of data on these patients. Obviously, with a fairly expensive category like factor, the plans and insurers are really trying to find the most cost-effective ways to purchase the products, if you will, or provide coverage for them. And often it gets caught up in a contract and discounts and so forth, and you can easily lose sight of the patient who's at the end of the line. And I think it's very important to make sure that you do have those emergency situations covered if that is the case. I know in my experience we did have that arrangement such that if we did use an external third party, that the patient could get something within a certain time window, and it was guaranteed in the contracts. And again, that doesn't always mean they get it, and those are things you need to monitor as a plan. But you raise some really good points here that it's about treating the patient in an urgent way when needed, and not simply chasing any finances solely as the driver behind these decisions. Is there any data on what percentage of payers have HTC 340B pharmacies in network, or the percentage of payers that require patients to use their own in-house pharmacy? And I'll take this one. I think that there's not necessarily data that's known at the plan level as to where these arrangements are and how many of the pharmacies are linked directly or are part of the HTC system. However, for those HTCs that don't operate an in-house pharmacy, they typically will contract with a third-party in-network pharmacy and are able to provide factor with some 340B discounts built in. And I think the plans really try to take advantage of that and in a cooperative way, working with the HTCs to include those pharmacies in the network. In my experience, we did have 3 HTCs that contracted with an external 340B, and they were simply in my network, and they were able to service patients associated with those HTCs very effectively because they were a direct extension of that. So again, the actual numbers and the percentages aren't necessarily important, but I think it is critical to allow these pharmacies to be in the network so they can service those patients and keep that continuity of care between the medical side of the equation, getting services through the HTC, and then the pharmacy distribution component. Our next question, do you consider the 5 to 10% variance recommended by Maysac guidelines well known, or does this need to be explicitly stated on each prescription?
Yeah, well, I would say that this is well known, certainly to the HTCs. Our goal, of course, is always to match what's on the prescription to what we actually want the patient to get as closely as possible. This variance is sometimes an issue. We have to write the prescriptions very precisely sometimes because of the requirements for the particular plan. However, it's important to also, I think, note here that we do pay very close attention to vial sizes and importantly, the number of vials. And so, sometimes in an effort to get that what's dispensed to what's written to match as closely as possible, if we give patients an increased number of vials to make up each dose to get those numbers to match as closely as possible, what we often hear from patients is they don't use all the vials. So, for example, if we give a large vial and then a very small vial to make the dose, patients will often not use that small vial. They'll just give the big one. Or this is a bigger issue if it becomes a 3 vial dose. They often are not going to use those smaller vials. So the issues there, of course, are they're not getting the full dose, and therefore they're not as protected from bleeds. And then importantly, then those extra vials then go to waste. And so while we do try to get these things to match as closely as possible, we're aware of this variance recommendation from Maysac. There's a lot of other stuff to think about there. And I think paying attention to that and making sure we're talking with patients about the number of vials per dose and how they're using it is important information to consider in this sort of an analysis.
And certainly from the health plan perspective, this is a critical issue and is often part of the contracts with those pharmacies that are dispensing, where there's a guaranteed, variance rate built into the contract that is a target to try to drive that dispensing and avoid waste. And you make a very good point. And a 5 to 10% variance in dose is also a 5 to 10% variance in cost. And given the base cost of these things can be quite significant. So we do try to manage that with our pharmacy suppliers to say we'd like to keep that variance within 1 to 2% wherever possible. And I think it's certainly well known from the plan perspective, and obviously the specialty pharmacies that are dispensing or the 340B pharmacies that are dispensing are well aware of that variance and do make an effort. And of course, that's a pitch that we get from the larger entities out there in the marketplace, that they have such large supplies of product that they can get closer to that target dose without having to provide overage, if you will, in terms of dispensing. So if we sort of underdose the targeted pharmacokinetic-based patient dose, is that increasing the risk of negative outcome if we're within that 4 to 5% of the prescribed dose?
Hemophilia is a very individualized thing, right? So for an individual patient, you might have more leeway than for the next person, and so for some patients this may not make a big difference, but for some patients it certainly will. And so I think we have to be mindful of that. It may make sense, when looking at it from a higher level, looking at it over a large population, this may make some sense, but we still need to build in the flexibility to make exceptions for individual patients for whom what seems like a small difference might actually make a difference clinically. So again, pharmacokinetic-based dosing we think is the best way to find that ideal fit for a given patient, and I think that's the strongest tool we have to make sure that the regimen we're selecting is the best fit to get those positive clinical outcomes for a given individual.
Thank you very much. Our next question, is there any evidence that requiring a yearly checkup at an HTC can help lower cost and increase clinical effectiveness for the patient?
Well, yes, certainly we have lots of evidence that HTC-based care is cost-effective care. So I'm maybe taking the question and translating into a slightly different question, but we have a lot of evidence in support of the notion that care based at an HTC results in lower costs overall, less ED visits, a shorter length of stay for patients that need to come into the hospital. The original data set from a number of years ago showing reduced mortality for hemophilia patients who had HTC-based care versus non-HTC-based care. So yes, we have a lot of data over the years that's accumulated showing the benefits of care that's centered from an HTC.
Great, thank you. Well, that concludes our question and answer session. I want to thank Dr. Redding for his time and expertise. To learn more on this topic, I encourage you to visit managedcarehemo.com.